My name is Rodney Fong, President and CEO of the San Francisco Chamber of Commerce, and we welcome you to this public policy forum about telehealth or telemedicine, as it's also called. This, to me, is a fascinating time we are in, and we are stepping right into the future, and the future is greeting us, whether we like it or not. So this is a great opportunity for us to talk about what's coming ahead. I want to give a big thank you to our member SF Tech Council, a multi-sector collaborative focused on advancing digital inclusion for older and disabled adults and bringing them together with experts in telehealth field to take a deep dive into what's coming up, what's going on in the future, where we might see things headed for the US and America. Want to thank our sponsor, Kaiser Permanente, for sponsoring this today. And I want to turn over for a quick introduction to the program director, Carla Smolala, to just say a few words.
Hi, everyone. Good afternoon. My name is Carla Sumala, and together with my colleague, Andrew Broderick, we serve as co-project directors of the SF Tech Council. And as Rodney mentioned, we're a multi-sector initiative that builds government, business, and nonprofit collaboration at the intersection of aging, disability, and technology. We're a one-of-a-kind organization nationally. We don't know of others that are quite like us. We were launched in 2015, and our mission is driven by the core belief that the most effective way to address the digital divide is to break down silos and bring people together to advocate for digital equity, collaborate on projects, and promote innovation. Depending on where you are today, you might be asking, is there really a digital divide in San Francisco, the center of the tech world? Well, according to the most recent numbers, and this was before COVID-19 hit, 100,000 San Francisco residents, or about 12%, lack meaningful Wi-Fi access. This disproportionately impacts older, low-income adults and adults with disabilities. Now you add pandemic to that mix, and we've learned a couple of things over the last year. First, the pandemic has further exacerbated the digital divide, and more residents are falling behind, especially in the target populations that I just described. And second, the pandemic has demonstrated that access, a device, and basic digital literacy aren't a luxury anymore. They're necessities to get by in daily life. So that brings us to today's focus on telehealth. As we'll hear from our experts today, in just 1 year, telehealth has changed the way healthcare is delivered for millions of Americans. And even as the infection rates drop and vaccines are being administered, fingers crossed here, we will never go back to the way things were before. So what needs to happen as we move forward? That's what we're going to talk about today. So if you'd like to learn more about the Tech Council and are interested in collaborating with us, I will put our information in the participant chat box, and feel free, and we encourage you to reach out, and we'll find something to work on together. Thank you.
Great, Carla. Thank you very much for organizing this and hosting this. We have 4 great speakers here today with us, and we're just going to have really a dialogue about what's happened this last year, which we've all experienced and been maybe forced to experience on a telehealth perspective, and really what's going to happen in the future going forward. I'm going to introduce our 4 speakers, experts. Scott Lean, the co-founder and CEO of GrandPad, has led the company in efforts to empower seniors of all ages, technology, skill levels to connect with family, friends, and caregivers. Courtney Lyles, a PhD and associate professor at UCSF in the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital, and with the Center of Vulnerable Populations, the Department of Epidemiology, Biostatistics, and currently serves on a number of San Francisco boards and foundations. Welcome, Courtney. Laurie Ovlov, a tech industry veteran, she writes, a speaker, a writer, an elder care advocate, and the founder of Aging Health and Technology Watch, where she provides thoughtful leadership, analysis, and guidance about healthcare and age-related technologies. And Graham Walker, MD, is joining us, and he is an emergency medicine physician at Kaiser Permanente here in San Francisco, and serves as an assistant physician in chief for technology and innovation. So we have all the right folks for this conversation. We have a number of people. I'm really pleased to see the turnout of this. There's over 70, looks like 75 or so on this. Go ahead and use the question and answer and chat room to pose any questions. We're just going to have an open dialogue, kind of a round robin, and if we have time, we'll address some of the questions. So with the housekeeping out of the way, maybe I'll just kind of go around and maybe start with Courtney first. If everyone could just kind of talk about 2020, even 2019, what we all sort of heard and thought about telemedicine, and all of a sudden we got this text from our doctor to click a link, and how people adapted to that, and what the challenges might have been.
Yeah, thank you so much for having me. Yeah, I think 2020 for me, to try to be brief, I want to hear everyone else's experiences, have really been about a rapid shift in the way in which we do work in healthcare that I think we've all been experiencing, mostly obviously to keep people safe and to move all in-person visits to remote modalities. I'm based at our public hospital and delivery system in San Francisco General Hospital. And for our patients who are primarily Medicaid patients, lower income patients in San Francisco, those with disabilities and other populations, this has meant a pretty big shift from ours, because we were not doing virtually any telemedicine care prior to the pandemic. So we have a lot of new workflows in place, a lot of assistance of our patients, but the data really shows that we've been almost doing primarily phone visits. With our patient population, we've not been able to do a large amount of video-enabled telemedicine visits, and there are multiple factors that I'm sure we're going to talk about here related to that, both on the patient side of having devices and broadband and Wi-Fi, as well as the skills to be able to do that, but also on the system side to also actually have devices and other things available to providers to do that at scale. We weren't, it was a rapid change for our delivery system, and we've learned a lot, and we've put a lot of effort in and actually have made a lot of great progress.
Great. Graham, from the Kaiser Permanente's perspective, I'm kind of curious. Kaiser has a huge presence here in the Bay Area, and even in the Bay Area, there are different demographics and sizes of facilities. In your opinion, has it worked unilaterally for everyone, telemedicine, telehealth, or has there been maybe a certain county or demographic that has been left out, quite frankly?
You know, I don't know that I don't know that there's a group, a demographic necessarily that's been left out. I think, you know, like we're talking about today, especially older patients. It really seems to be more access to technology and what I'm kind of calling tech literacy as well. You know, technology is great, and it has really helped us and forced us to change and adapt. And like other people have said, I don't think we're going back for a lot of things, but technology is still, even with, you know, Apple iPhones that, you know, really try to be as easy as possible. I think really the biggest area where people still struggle is if their technology doesn't work, if they can't get their Wi-Fi working at home, or if they don't have a computer or a smartphone. If they just have a flip phone, all of these features of, you know, video enabled care, they're not possible. So it's really access to the technology and then having the technology working. You know, we often will have like our medical assistants trying to troubleshoot people's Wi-Fi for them to get ready for the doctor appointment in 15 or 20 minutes. And we, you know, we're not, we've kind of learned on the fly how to troubleshoot Wi-Fi networks and get people to connect to Wi-Fi or turn off Wi-Fi so you can use cellular. So it's been a challenge in a lot of ways.
Okay, great. Thank you. Laurie, you are tracking all this from different perspectives and writing about it, and being an observer of different users of this. From your perspective, this last year, this has got to be sort of a boom year for you as far as stories, sharings, maybe even difficulties as we learn how to do this the best way.
So I think it's been a big year for the growth of telehealth, I think. And one of the things that I noted, really starting in the summer, I decided to write a research report called The Future of Remote Care Technology and Older Adults. And I did that because I saw a significant problem If people can't go to the doctor in person, what are they going to do? And what are the organizations that try to serve them? What are they doing to mitigate it? And so just like some of the tactics described that Kaiser's doing, many organizations actually did decide to do something. And one of the things I thought was interesting is that the utilization of telehealth, which actually exploded at the beginning of the pandemic to 26.8 million telehealth visits, including all the reimbursable formats, such as phone, primary for many older adults, Skype, FaceTime, etc. The other thing I think is worth noting is that nearly half of Medicare beneficiaries' primary care visits during April were provided by telehealth, about 43 or 44%. I think it's pretty clear that the switch caught physicians by surprise, as you saw, and hospitals also by surprise. There was a learning curve. But by July in 2020, we note that telehealth visits began to decline as in-person visits began to pick up. And at the end of 2020, I believe it's going to be the case, and moving into 2021, it's going to be the case that most provider groups are now going to offer a choice. Would you like to schedule it when you're scheduling? You want this to be an in-person visit if you're in a location where that's feasible, or do you want this to be a telehealth visit? So I think that's been the big deal.
Great, thank you. Scott, I sort of saved you for last because I'm really curious about what GrandPad is. And in your bio here, note that you started this business with your son, Isaac. So I'm curious to hear and tell us about GrandPad.
Yeah, thanks for having me on the program. And yeah, we started GrandPad 7 years ago to solve an issue that we saw in our own family, where my 80-year-old mother, who's a brilliant lady, ran her own business, was just frustrated with standard technology. And it was during that process we learned that these wonderful devices all of us young people carry were designed by 30-year-olds for 30-year-olds. And my mom, being the brilliant lady that she was, said, why hasn't anyone designed a product for me? And that was kind of the lightning bolt for my son and I, and said, let's build, just like you wouldn't expect a 3-year-old to drive a car that was designed for a 30-year-old. Why should we expect people? And I'm 57 now, and things are starting to get a little bit small, and buttons hard to press for me. So we just designed a product from scratch with 80-year-olds in mind, and 80-year-olds helped us design it. We have a group of grant advisors. All of them are in their 80s and 90s. Our chief grant advisor is 91 years old. Our oldest employee, Elmer, was 106 years old. So they help us with the ideas, the design, and the testing. We're just kind of the hands that build it for them. And that caused us to very systematically remove all the points of frustration that was creating the digital divide with this age group. This age group, and we lovingly call the folks we serve super seniors, those over the age of 75. They want to be connected more than anyone. I mean, they really want to be connected with their family, friends, and their circle of care, their doctors, nurses, clinicians. So there's the desires there, but we had built in, us young people had created all these obstacles. We call them points of frustration or poof points. And it could be things like the packaging. Go buy an iPad at the Apple store and set it in front of a 90-year-old one still in the wrapping and say, please open this and send me an email. We found it's close to 0% are able to do that. And the packaging itself is a huge barrier. Small, everything's wrapped in those shrink wrap. It might have a clamshell on there. You need a knife and a hammer to get out. So we rethought all that. Simple packaging, simple things like a wireless inductive charger. So you set it on the wireless charger and it's charging. I don't have to plug in a lightning or USB adapter that may be small and hard. And the connectivity is a huge issue, as the previous speakers mentioned. Wi-Fi access either isn't there, don't know the Wi-Fi password, or doesn't reach and isn't reliable enough to do a video call. So we built in 4G LTE that really works well. And so just systematically solving every point of frustration, building a product explicitly for this age group. And now our average age of our users is 84. Our oldest user currently is Hester, is 116. She's the oldest person in the United States. So when you build a solution for them, they love it. And then it opens up all these opportunities, including telehealth.
That's fantastic, Scott, and congratulations on that. And I think any of us who have tried to help a parent or grandparent send a fax or send a text appreciate your work and creativity there. It's actually a perfect segue into the next question, which we could just feel free to jump on this one. But it's really, the question is, what are the challenges going forward beyond 2021? And it's really amazing what we've done in just 1 year. And the speed in which technology can take us places, but there are limitations. Some of that is broadband and speed, 5G, rural areas versus urban settings, cost, and do people have the money to purchase or access to a computer that's got a camera on it. So if we could also just think about, I know much of the conversation has been about the older adult, but the disabled community as well. Those who are just not so easy to get out of the house to go to a visit or to go to a friend's house who's got a computer, and how we're going to try to serve all of these communities equally, compassionately, using technology like Scott has come up with. So if you can, maybe just talk about some of the challenges. They can be physical ones, they could be language barriers, they could be fears about who's listening on the other end of this call, privacy. So Courtney, and you're nodding your head up and down. Maybe you have some thoughts.
Yeah, of course. I don't too barrier focused, because I do think there's some good strategies too. But in terms of the barriers domain, I think we have to start with some structural systems in our country, and how we've thought about broadband access for communities. And I know in San Francisco, we're very fortunate to have an initiative on digital equity that sits in the mayor's office of housing and community development, who thinks through broadband in public housing. I'm talking about the wires built into people's homes are actually not available uniformly in the United States, and that affects rural communities like you mentioned, but it actually also affects urban communities disproportionately, specifically communities of color, certain senior housing buildings, other things that we need to be really thoughtful. I would say it's broadband as a utility. And I think people with young children all the way through older adults have experienced that in the pandemic, and have an advocacy movement to think about that in a different way. And then we already talked a lot about the literacy needs, so I just to emphasize those. My feeling about that as the patient trying to experience telemedicine is really about designing for somebody who has less digital literacy, or for somebody who has different ways of interacting. Usually makes the technology better for most people. It's not as though, so thinking from a simplistic viewpoint and thinking through older adults like GrandPad, I think can actually help with a lot of groups who haven't grown up with technology, immigrant populations, lots of other groups who are newly learning skills and tasks. And then lastly, I just want to make a real quick plug at the system level, like providers and teams have to offer telemedicine. And I just want to make sure that everyone knows that they also need support and assistance in doing this. It's a really big lift for them to be able to do this. And I know Graham will probably chime in more there, but to really rethink the way that they've done care. And in our population with many non-English speakers, how to get interpreters on the line, video medical interpretation, additional assistance. I mean, all of that really takes extra time. And how do we build that into the new environment that we create are really important goals.
All things that you don't think about unless you start to get really into it. And Graham, maybe you've got some thoughts about how Kaiser has stepped up here. And I'm actually kind of curious if someone like Kaiser is working with big providers like AT&T or T-Mobile in forming partnerships for better stability.
We started to investigate, this is kind of the opposite of Scott's idea, which I love. We were even, trying to brainstorm ideas like, could we just send somebody a iPad, a cheapo iPad that's preloaded, that's just for them, and it's got LTE on it, and all they do is turn it on, it's pre-charged, and literally they just hit a button to get logged in, and then they can start the video visit, because there are so many issues with being able to access some of these patients. We've had a community care program that goes into people's homes who are either homebound or don't want to leave their homes. Or have difficulty leaving their homes, for physical therapy, for nursing care, for provider care. And we actually just recently added on courier service to deliver same-day medications, like via Lyft as well. We have a mail order pharmacy, but this is like, hey, your doctor thinks you need to start these antibiotics today. Lyft will actually drop off antibiotics to your home, which is pretty amazing. The area we've found still have issues with are, like you mentioned, English literacy as well. I mean, we have an incredibly diverse population in the Bay Area, San Francisco specifically. Our apps tend to work in English, obviously, primarily, and then translations into Spanish and Chinese. But we don't have Russian, we don't have Vietnamese, we don't have many other languages available. We did in 2019, even pre-pandemic, launch we have an internal app that will actually switch between. You can literally within seconds get like up to, I think, 250 different languages available with an interpreter. I mean, I've like even tested it before, and I've been able to get like an Urdu interpreter in like 5 seconds. So technology for translation has been much better. For people that speak ASL, we can now patch in ASL as the into a video visit with the patient and the provider, and have the ASL interpreter be the main person on the screen to help with that as well. The last thing I'll say that is for hearing impaired patients, especially older patients, the iPad volume can only go up so high. So like as an ER doctor, I can literally be screaming into the phone, trying to get information from a patient on a phone call, on a video call. But if it's just not loud enough for them to hear, if they don't have headphones or some way to amplify the sound, that's another struggle that we weren't really prepared for as well.
Yeah, I'd love to comment on that if I could, because the hearing issue is such a big one. I mean, for the elderly population, it's half of that age group have significant hearing loss. And my mom, who, as I mentioned, was our first customer who we designed, had significant hearing loss. So that was one of the things we thought a lot about. And I was smiling when you said that. We built in, one of the problems is a lot of tablets or phones, the speakers, we built in dual front-facing speakers of the sound channel. It's the loudest tablet. And we actually then also optimize the sound for the average hearing frequency for elder population, which is different than younger people. And it made a huge difference. And so because telehealth, if they can't hear the clinician, it's useless. We also built in real-time texting, so the clinician can speak, they can see, they can read lips, but then they can put the words right on the screen. And of course, captioning is available. We actually found the clinician wants to put the specific words. We're talking about take 33 milligrams of this medication. Like, you can't have the captioning mess that up. The doctor can type it precisely, and as he or she says it, put it on. So I think those are the kind of adaptations that are so important to make telehealth work for elderly, but any a group that might have some impairments. The other thing I would add in terms of the challenges going forward is, of course, the cost, the expense matters so much when we're talking about doing massive rollouts across the country. But I think the thing that we've seen is you've got to look at total cost of ownership. And we've seen a lot of situations, especially in a nursing home, assisted living type situation, where really well-intended folks are donating, used equipment, used tablets. And now the caregivers who are just over-max taxed are trying to configure and help. And you see them carrying around and handing a tablet and trying to help a elderly person with a Skype or FaceTime call. And now you've actually created a burden on the caregivers. And I think that's a cost that's got to be accounted. And so I think that's where, as an industry, we've got to come up with solutions that are well thought out, that attack the total cost of ownership. And the last point there is on the data connectivity. I do think that wireless is the way to go. 4G, moving to 5G over time, but even and that works really, really well, and actually now is at a cost-effective level. And moving in rural areas, we're even testing the satellite-based solutions. So Starlink, Elon Musk's latest venture, you can plop the satellite out. You live in the middle of Wyoming, you now can have super high speed. So you can get those people that are in areas where there just is no wired connection. And I think that will hopefully be the great kind of unifier that brings that. So now we have access to those things. And lastly is, I do strongly believe that if used properly, there is tremendous efficiencies. I mean, there is a lot of opportunity across our whole healthcare system to make things more streamlined for all parties, the payers, the providers, and the consumers. And I think we have to use technology as a catalyst to drive those efficiencies to take cost up.
Mm-hmm. Very good, Scott. You know, I'm going to go a little bit out of order because there are a couple of questions here that are sort of focused at GrandPad. The second to last one is there any work being done with insurance companies to include reimbursement for such technology? What does that landscape look like as we start to roll out hardware monitors? And my later question to everyone is, you know, more devices like this, whether they're watches, but are they going to be part of a package that is a medical package or insurance package you purchase?
Yeah, I'll comment. So yes is the answer. We are working with different payers and providers on that. I think there is still an education process going on with the various regulators and CMS. You know, there's this, you know, what is considered an inducement, right? And is it something that's being used to get people to sign up for, you know, a Medicare Advantage plan? And so I think as a community, we can do more about educating people about the true healthcare benefit, especially. I think there's things that are clear from a healthcare standpoint of, hey, we need to monitor blood pressure, someone with diabetes, glucose. But on the mental health side of things where we're by using video calling to bring community together to help reduce social isolation and loneliness, and that's going to prevent other downstream costly mental health impacts. I think we've got to do more as an industry to educate the regulators on that, such that the funding is there and that we know that you know, investment to prevent the problem is worth it. But that's what we're seeing. And I would just mention also is I think there's some really unique, great programs. The PACE program for all inclusive care for the elderly that we've gotten involved with is a great program to help people, you know, dual eligible folks that, you know, low income with high healthcare needs, and where they're looking at, hey, what is the most efficient way to provide outstanding care for these folks?
Great, thank you, Scott. We have close to 90 plus people on this call, which is fantastic. I encourage you to use the question and answer chat room, and we will save this as well. And folks, the panelists can get back to you if we're not able to answer the question on this call. Laurie, real quick, back to the challenges from your perspective. Do you see, what do you see as the largest obstacles going forward in the coming years here?
Well, I think there was a great survey done by the University of Michigan that was, I also put in the report, that people have concerns about telehealth visits, including the fact that they are lacking in a telehealth visit the physical exam, which they believe, especially for many particular conditions, reduces the quality of care in comparison to a telehealth visit. So I think that's one of the factors. That survey, by the way, was age 50 to 80. They also have had concerns about, and the ARP has also noted this, lack of training on how to connect. And whose job is it to train people on access to the internet and access to telehealth technology? I don't know if you all saw a recent survey done by Humana in conjunction with OATS, the Older Adult Technology Service. But what it indicated was there were 22 million people, 65 plus in the United States, who lack broadband. And we talk about, cellular may be great, but cellular is not so great for doing a lot of the things that would also improve the quality of their life, including the ability to communicate more effectively with families in video sessions, but also to access information in the full form in which it's actually available on the internet. So that's another one. We already mentioned the fact that half of the 75 plus population has hearing loss. There are people out there who have, quite a few people actually, who have dementia and who are unable without assistance to participate in a telehealth visit. And there's people with age-related macular degeneration. So those are all barriers about individuals. And I think the other barrier that we haven't really talked about is for older adults who live in senior living or nursing homes, whose job is it to support them with telehealth access or any form of connectivity access, assuming that the facility actually has that kind of access available.
Okay, thank you. Great. If we could shift now even more into the future. This is the cool stuff for me. This is the Flash Gordon. Will there be a watch I wear that pings my doctor when a certain elevation in my biology comes up? What does the future look like for other devices? Obviously, Scott's got the great GrandPad there. Are there going to be more wearables? Will someone check if I'm taking my meds and ping me if I'm not taking my meds? Will I get a little bit of a vibration or zap if I'm not making enough steps per day, where we already have that? But I'm just curious where this folds into our daily lives in a non-obtrusive way, in a helpful way. Really helps some people with a lot of things that they need maybe help or guidance or training with, diet, et cetera. And curious where you think this is going. I asked the question because it's, for the whole globe, this is an important piece, but for the Bay Area, which is the tech leader and the bioscience leader of at least the North America, maybe elsewhere, all these things can happen here in San Francisco. We have the talent to do it. We have the ingenuity. We have the financial capital, I believe, to make these things come to light very, very fast. And so a little bit of where the San Francisco is right now, and you've all read about the exodus and tech potentially leaving. Well, I really feel that the medical world and the bioscience world is really the future of San Francisco. So this call is important for everyone listening here to see where we're going. But if you can talk a little bit about the physical devices that maybe are coming out. Graham, you're kind of nodding your head, something that maybe once you see a patient, you send them home with a wristband to monitor the progress, something of that nature.
Yeah, it's interesting. In my personal life, I just got an Apple Watch a few months ago, and I'm sure it will tell me to stand up during this call. Personally, it has helped me a lot. It's motivated me to exercise, to stand. I think it's made me a better husband because I actually am like, oh God, I guess I'll stand up and do the dishes or something like that. Professionally, I have not, unfortunately, found like the Apple Watch to be particularly helpful with my patients. I find most of the patients that come to the ER and they say that, my Apple Watch told me my heart rate was too fast. It has not turned into a subtle new diagnosis that would have been missed or something like that. And that's what the research is really showing. So that the Apple Watch, while it does detect some arrhythmias, for every one that it does detect, it's like 8 or 12 false positives, and leads to kind of tests. And honestly, for my patients, a lot of anxiety that doesn't really help them. And we have plenty of anxiety in a pandemic world. In the future, I think there is a strong possibility that devices may help us, and that we may start to incorporate some of the Internet of Things, of patients wearing devices, into the medical record, or at least doctors having a section of their note that includes, well, here's what the patient's telling me, here's what I find on my physical exam, here's what I find on the lab test, and maybe here's what I find on, here's the data that they're providing to me that helps me make the diagnosis or see what problems that they're having.
Yeah, I just want to chime in because I think I have from the same more healthcare lens, is that I think there's so much potential for some devices and wearables, but I think I'm in the same position of Graham, as like some of the basics in the healthcare system to take in that data and to use that data effectively aren't really quite there yet. And I think what the pandemic has shown is that communication with the doctor and just visits with the doctor is hard enough, on top of then we have no vitals, right? We can't even, it's been challenging to get the vitals, and mostly for chronic disease in older adults, like blood pressures and blood sugar levels and things like that. Those are the most important, probably weight measurements for those with heart failure. There's some top ones that I think there's a lot of use cases for, and those would be the first in my opinion, that are from a healthcare and public health input that we need better systems to. But those same people who have those conditions are unfortunately the ones with the biggest barriers in terms of digital literacy and connectivity. And so the reason I think, there's lots of lifestyle and wellness programs that are really promising, but we have to start with the fundamentals, which I think all of us on this call are thinking about to be able to get there and to envision that future.
I would just add for connected health digital devices. So we have a connected body weight scale that integrates with GrandPad, and it's direct connected to the cloud. And with the population we serve, with super seniors, we found that to be very, very natural. You get up in the morning, you brush your teeth, step on the scale. Now, not only are you providing your body weight, and if you see big jumps in body weight can indicate, issues of retaining fluid or congestive heart failure, it's a good indicator, but it also sends a ping out to your circle of care. I'm up, I'm okay. So a very simple way to do that. Some of the other wearables, and again, that's good because it's easy. It just sits there. It's got lots of batteries in it. The batteries last literally for years. And the one we have is direct cloud connected, no Wi-Fi or anything needed. Some of the other wearables, love Apple Watch. The problem for this age group is battery life. And so the challenge to all the brilliant innovators in the Bay Area would be, we've got to get some breakthrough on battery, because for younger people, maybe charging an Apple Watch every night is okay. But for a super senior, it's hard to take on and off. It's hard to get charged. And now when I get up in the middle of the night and go to the bathroom, when I need fall detection the most, the thing is sitting on the nightstand charging, right? So we actually, and I'd love to come back a year from now and share some of the things that we're still working on in the labs, but really more ambient passive monitoring. So things that are just plugged in your house that are helping monitor basic health, wellness, safety, security, but then also things that are built in to the video stream itself that are monitoring those. So we're working on some really cool things that, again, for the population that we serve, it gets over this physics issue with battery life, and it doesn't become a burden and awkward to use.
We cross a little bit into the smart home conversation. Just smart home and fall technology, and when the lights go on in the bathroom at a particular time of night, etc. Sorry, Larry, go ahead.
I just want to mention a few things about wearables before we wander off of that one. First of all, there's an enormous industry called the Personal Emergency Response System industry, which is the medical alert pendant. That has gotten a lot smarter in recent years and includes capabilities like fall detection, includes capabilities like being able to be out and about. And increasingly, one of the things we're going to see is the integration of ambient technology in the home, as well as devices on the body that actually integrate with AI and predictive analytics to say, if your behavior is such and so, and over time it changes to be something else. For example, there's a smart scale out there from a company called Zibrio that you keep weighing yourself, and after a while it notices that there's something changing in the way you're standing on the scale, and says maybe there's a deterioration over time, and it could offer some advice to people who are connected to the use of that scale. So I think that's one thing. I am going to write a report maybe in this coming year called The Internet of Behavior and Older Adults. This was an idea that Gartner introduced that says we give off a lot of information that is actually used to sell us more stuff based on the wearables we're wearing and where we've gone and tracking us and all kinds of things like that. You could say that has a lot of negative implications in the future, but you could also say for populations like older adults, but others who could, people with disabilities, the tracking of us could provide insights into what we're doing and giving us advice that we could actually use, that we could benefit from about, you're going over here all the time. Did you know that there was something else in your region that would actually be of use to you? So I think we should think about the role of AI, the role of the Internet of Behavior, and the idea of predictive analytics to help ward off issues that we may encounter in our daily life. I think you're muted.
Yeah, sorry, Laurie. That is fascinating. That direction of tracking patterns, how they change, how we change. We're all changing constantly, daily. So that is great. Maybe I just kind of wrap it up with like kind of a closing comment, if any of you have it, and what to keep an eye out on. There are a few questions in there if you want to try to address those. Many of them are towards GrandPad. And so Scott, maybe you got a couple of friends, family on this call that submitted some good questions you want to try to answer. And then we'll close with some closing comments.
Yeah, if you'd like me, I'm looking in the chat room. I think there's some questions around cost and how it can be covered by Medicare and so on. I think one thing I would just clarify, I wish we were in a position to give GrandPad or like products to every senior, super senior that needed it, because I think there's so much upside benefit to them to improve their life and healthcare savings that would result from that. But our product, the way it's priced, it's a SaaS or monthly subscription, and it includes the hardware. So you don't buy any hardware up front. You don't have to go buy an iPad. You don't have to go buy a case and a charger and all the little add-ons. All that's included. But the biggest thing is the 4G LTE cellular data service is included. And my cell phone bill is more than $80 a month, but for GrandPad, that's included. We buy data in bulk, and there was a question about which carriers. We support the major carriers in the US, Verizon, T-Mobile, and others. Our product's also available in Ireland, the UK. We support the major carriers there. We're able to buy wholesale bulk prices, so actually cheaper, and we can pass that along. So, there's no limits. The senior doesn't have to say, oh, have I used 2 gigabytes or any of that? It's just included. If they need to do telehealth visits with their doctor every day, they don't have to pay extra for that. They do not need Wi-Fi. The average cost of Wi-Fi in the US now is right around $55 is the average. So you get the hardware, you get the software, but the biggest thing, and this goes back to some of the barriers, is support. And the healthcare, all the caregivers, they don't have the time or the resources to be doing tech support. Some of the other speakers talked about trying to debug Wi-Fi and so on, which is immensely complicated. We have 7x24 customer care included for the senior, their family, or their caregivers. Again, we do that at scale and do that in an efficient way. So that's including, you have to pay extra for that. So that's a cost, and no contracts and those kind of things. There's also some questions about coverage of through various funding sources, Medicaid. That is something that we're working on. We're working with partners, a number of the PACE providers, so they provide their service, and then GrandPad is included with that service. So they're not, it's not an extra add-on, it's just part of their care. And I think that's a great model, because then there's a caregiver that's part of that as well.
Great.
So I think hopefully that answered a few of the questions, Rodney.
Yes, thank you, Scott. Courtney, any closing thoughts from UCSF?
Yeah, I had two thoughts. One of them is in the chat about what we can do on the front line to partner with community-based organizations. And the way in which I think about this is that digital inclusion, both the devices and the data, broadband plus the skills, are sort of in the line of a social determinant of health, where we ask patients about what their needs are, and being able to understand what they're having, where their barrier is, and refer them out into community partners who have way more expertise in helping them sign up for the Lifeline program, or low-cost internet at home, or skill building at the public library, or other nonprofit groups. And I think that is a way forward. There's some of that happening, but I think there can be even more. So that's a strategy. We've done it in some ways, and I think it's a really promising strategy moving forward. And then the second I wanted to close with was from the policy standpoint. There are a lot of questions about payments, and I would say the more in which we think about healthcare payments as for the whole person, and thinking through what's best for prevention for that person, we're still in a disincentivized way in many healthcare systems to think about that. But the more closely we get to that vision, I would say technology not as an alternate, but some people can choose it, and then looks like some people aren't interested in that technology, but really as the fundamental way that we would deliver care, and not leaving certain groups of payers behind, like Medicaid, or certain groups behind, seeing that they don't want those technologies, is the wrong way. So how do we have a policy and reimbursement mindset that can actually have a long-term vision? Because many patients do want this, not all of them, and how can we work towards that, rather than just thinking about the most well-resourced individuals up front. So those are my two closing thoughts.
Yeah, fascinating on the policy front and where that takes us. Laurie, any closing comments?
I have one thought that I think should be in every medical practice, and I'm not sure that it is in every medical practice. So let's say the patient actually comes into the office. While they're sitting there waiting, is there something on the video or a brochure sitting next to them that suggests for future follow-up visits, here's some information, getting started with telehealth, why and how? That's what I'd like to see.
Good point. This is an education for all of us, and wherever we're sitting in the waiting room or online. Graham, any closing thoughts?
Yeah, thank you. I'll say a couple things briefly. Rodney, you mentioned that in July, in-person visits kind of started to return, and that's the same that we saw within KP. We are finding the right balance, and one of the few positives of this terrible year and this terrible virus is it really has forced healthcare to innovate and embrace video care in a way that I don't think we ever would have been ready to or would have been forced to. And so that's been a profoundly good thing. I think we're now finding that right balance of based on the patient and their chief complaint and what issue they're having. We're getting much more comfortable and much more savvy with, I think we probably could manage that by video appointment or even phone appointment or even secure message. Or, hey, in my experience now, I think this really is something that you need to come in for, and I need to see you, or I need to get a lab test, or what you're saying is concerning me, you need to go to the ER. The other two kind of public health things I just want to say. One, if you need to go to the ER, we will keep you safe. We are vaccinated. We wear protective equipment. Please do not seek care because you are worried about COVID. We will keep you safe. I've seen way too many patients who have been sitting on their belly pain or their chest pain for days until it's to a point that it's much more of a severe condition because they are just terrified to leave their homes. We will keep you safe. If you need an ambulance, the ambulance will keep you safe. And then the last thing I'll say to everybody is, please, if you qualify for a vaccine, I strongly recommend getting a vaccine. There is so much misinformation out there. I am fully vaccinated. My elderly parents have had their first vaccine. Hi, Mom, if you're watching. Please get your vaccine if you are considering getting it. You can go to Moscone with an appointment and get vaccinated. If you're 65 and up, if you're 75 and up, most of the health systems are being mandated to use 75, but the city is using 65. You can go to any place. If you're a Kaiser patient, you can go to Kaiser. You can go to anywhere that offers a vaccine. Please just get vaccinated. The data is really good in Israel that almost all of the new infections in Israel are people that are not vaccinated. I think it's like 97% of cases post Israel's vaccine push is from unvaccinated people. So it really does save lives, and it really is safe.
Graham, thank you very much for those reminders of us to visit the doctor if we need to and to get vaccinated. It's so important. This has been fascinating. I want to bring on Carla to kind of help close us out. And thank you again for SF Tech Council for putting this together. This is, I think we just spent 49 minutes or whatever, just scratching the surface of this. I would love to reconvene in 6 months and maybe 3 months and see how this is all going to change, and all kinds of questions in my head are bubbling from a business perspective, of course, being from the Chamber of Commerce. But this is a whole new industry. And we were, as you pointed out, Graham, sort of forced to do this, but maybe that's good. Maybe those kind of uncomfortable moments are what to push us the boundaries, to push us even further. So we certainly see that in the vaccine technology. Carla?
Great. I just want to thank everybody for joining us today. And I also want to give a shout out to all the community-based organizations that are out there helping to make this happen. We did a lot of focus on the kind of tech that is needed, on costs, but for all of this to be successful and to continue to work, there are lots of smaller organizations out there who are doing the day-to-day work of this. I'd like to give you the example of Adult Day Health Center in Bayview Hunters Point in San Francisco. They serve a largely very vulnerable, frail population, as they describe. Renika Butler is there, and they've done a rollout of iPad, but they're trying to use tech to fight social isolation and loneliness. different things like that. There are other organizations like Community Tech Network, also in San Francisco as well as in Texas, and they are in the process of developing a curriculum to help older adults get online with their medical care providers, using it for a number of different insurance companies, as well as, you know, different kinds of providers. Every provider has their own platform. And so it's not a case of just helping somebody talk to their doctor. We have to figure out what system they're in. Is it Kaiser? Is it Sutter? Is it, you know, those kinds of things. And so we've got community based organizations who are doing that kind of thing. Community Living Campaign, our fiscal sponsor, is doing a lot of work on these digital literacy issues, and really trying to help people do these very basic things to get online. Some of the things that you and I are taking for granted as we move through the day pretty seamlessly with our tech, and are able to, you know, communicate with others and get things done that we need to get done. And so I think if we do have just a minute or a few minutes left, we have until the hour, if anybody could speak to the ways from your perspectives that these CBOs can be more effective, and other ways to form partnerships, if you have any insights on that.
Yeah, I can chime in quickly that I've worked with the Tech Council and some of the community-based organizations that you mentioned, and we worked with another one in the same space with Community Tech Network, and also the Little Brothers Friends of the Elderly, LBFE, to train older adults how to use technology in their homes. And I would say in doing that, I think each of us have really complementary skill sets. The healthcare system sometimes puts extra barriers, I'll fully admit, up to signing up for different platforms, and they have a lot of privacy and security demands. But we can partner better together, and we show that people are interested. They need different types of training, longitudinal training and relationship building, to try to really practice skills and be able to learn how to use technology. But that healthcare is one of the main things that they really want to learn to use, not only because they're sort of forced to at this time, but also because it's one of the number one things that they want more information and access to their doctor. So I could just to personally comment that I think that they're doing amazing work, and better ways of incentivizing us to work together across the silos and different programs, I think would be really impactful moving forward.
Yeah, I would add, Carla, I think companies like ours, we're a for-profit company, but our extremely mission driven, our focus on, doing well by doing good. And we're very open to figuring out how to structure a program that works for a community organization, a nonprofit. I would highlight, we just announced actually yesterday a partnership with the St. Louis County Library in St. Louis, Missouri, where they're making grandpads available to their community for elderly folks in need, where you basically can check a grandpad out for a year, like a library book. And it was really thoughtful, and they were able to get some grants, and we were able to tailor a program that worked for them. So I know there's, we are, and there's lots of companies like us that are mission driven that want to figure out a way to partner and help.
Great, thank you. There are many questions here that we didn't totally get to, but there are good ones. And one of them was, is this going to be a reoccurring forum? If there's interest out there, I would love the Chamber of Commerce to continue to do this, because it's going to be moving so fast that I think all of our members would be interested in it. The Chamber of Commerce this year is 170 years old, and people think about it as a business organization. COVID has shined a light on San Francisco that business is connected to everything. The health of the city, the residents, the society, the transit, the housing stock, those unhoused are a huge piece of the business community. So we are plugging in everywhere we can to help shape the city and make it even better than it was before. Two things I want to just make mention. We have a City Hall check-in, and those of you are eager to learn more, we have Tipping Point, and most people have heard of Tipping Point, coming on February 17th to talk about homelessness and street life. We have Supervisor Raphael Mandelman coming on March 1st. He's one of our 11 supervisors here in San Francisco, and has written a lot of great legislation for San Francisco. So please join those two. I'm going to kind of wrap it up, but before we close it out, if we can maybe save the chat questions, and then Carla, if you want to maybe go through them and answer them back or reroute them back out. But I thank everybody, our panelists, for coming. This has been really educational for me, and I'm sure everybody else. Just the beginning. We're just scratching the surface. So thank you very much for joining and participating, and we'll see you next time.